those who join us now. A special welcome to those who started early in the morning. If seriously, I'm really, really happy we managed to go through these 4 days and we survived. And more than that, it feels we're thriving and full of new knowledge, me included for sure. And I'm really grateful to both groups, presenters and participants. And I don't know even who more, because to take it in and process and think through, it's huge. So as I said, we have, after lunch, we have this incredible lady who's incredible in many, many ways. And if I start talking about her, we won't have time for her presentation per se. So without long introduction, this is professor at UBC at School of Faculty of Medicine. And her name is Dr. Chris Look, and she's one of the biggest advocates of social pediatrics here in British Columbia, doing an amazing job, and also a British Columbian Korczak. So we have the best parts of the two worlds. On the one hand, social pediatrics, medicine, and Korczak. All yours.
Thank you, and thank you all. I am here as part of a team. I'm honored to have one of my team members here today. Well, actually two, including our newest member, part of our Social Pediatrics Richer program. I am a developmental pediatrician. My purpose today is to share the journey of this 13-year journey with this team and what we call a richer model. And I will explain the acronyms. That my gift in the team is that I like to put words into acronyms so that we remember things. The talk that I'm actually sharing with you was put together with my colleague, Dr. Judith Leinen, who is a professor of nursing, now emeritus at UBC. And this journey that we started 13 years ago as my middle child was going off to university, and she heard about this maverick pediatrician who was working outside of Children's Hospital in the community and thought it might, and was willing to break the rules a bit. So I, like our colleagues saw on the East Coast, and as we're coming to see in the model of Korczak and other Korczakians who think that we should be doing a different kind of care. This small piece this afternoon is to give you a concept of the research and the foundational work that was done to look at changing the way we deliver care to children, and has so nicely put together in one of Dr. Julian's book called A Different Kind of Care. And I was caught this morning by those who preceded me to describe a model. I called a model a medical home for healing children who've been left behind. My mentor would have said social pediatrics is about who we're not seeing and asking why. It's not about who comes to Children's Hospital. It's not who comes to a doctor's office. It's about who isn't coming and asking why. And as Tatiana started, she really stressed, Korczak stressed the interprofessional nature of what we do from medicine, sociology, ethnology, poetry, criminology, a prayer book, a handbook for animal training. That may be how I work with my husband, but pedagogy, psychology, and also he said the child care is, the child care institution is both a research, it's both research territory and a child raising clinic. And what I'm describing to you is about this research to practice model that was developed with the community, driven by the community's interests, and a partnership between the university and a children's hospital. I like to think of take-home messages, and this is something that I put together for Tuesday morning rounds with my surgical colleagues. We've developed a lot of understanding about what are our indicators of risk in children, but surgeons like it fast, and so the acronym BEARS, barriers, I actually picked the spirit bear, which is the white bear, which is the more special bear. So from the spirit bear, the barrier stands for barity or equity or inequities, adversity, R for resiliency, and S for social capital. The spirit bear, it's social pediatrics that has the rights of the child for participation, for provisions, and for protections. That's integrated. It's an integrated social medicine approach. It's responsive to the rights of children. It's interdisciplinary, intersectoral, and we work as teams. So RICHER stands for responsive, interdisciplinary, child health, education, and research. And we require our team to recite this every community round. What does RICHER mean? It's not for richer and for poorer, in sickness and in health. This was the name of our first CIHR, that's the Canadian Institute of Health Research grant, that talked about a change in the way we deliver health services to more socially vulnerable children and families. So to back up to what I put at the front with my take-home message is, if we're going to communicate to our colleagues, we have to be able to communicate so what we're looking for and how can we dismantle those barriers, how can we address the social determinants of health in the context of toxic stress, the adverse childhood experiences, to look at the resiliency not only of the individual child and family, but where is the scaffolding for resiliency? Where are the resources within the community to enable a child to reach their potential? And to stress the importance of social capital. And this morning's workshop really brought that together in a real case about a real kid, and about the whole part of looking in the best interest of the child means listening to the child and what's the child's right and the child's best interest. So just the backdrop of where we are, 1 in 6 kids live in poverty in Canada. I work especially with children who have developmental disabilities and birth defects. 1 in 2 children with disabilities are living in families that are receiving government benefits. So not only do poor kids have poor health, but if you have a child with a disability, at least half of those children, those families are experiencing more adversity due to their child's extra needs. And we know that 1 in 2 status First Nations children live in poverty. The research is clear that social and economic status is linked with higher rates of infant mortality, poorer mental health outcomes, and using more acute care and receiving less preventative care. We're sitting in the poorest province. We're not poorer than the territories, but the poorest province. So we have the highest provincial poverty rate. As I said, social pediatrics is about who we aren't seeing. It truly does take a village, and that the solutions around these inequities are going to rest in interdisciplinary services, plus access to richer, responsive, intersectoral, interdisciplinary, community-based, child-focused services that include education and research. We are the training ground. I am so pleased that I see people half my age here. I am so tired of going to places where they're only aging women, and I go, where are the men? We've frightened them away. They belong in this discussion. And where is the next generation? And we need to talk about looking at environments that foster resiliency and build social capital. This is not a medical model. So this research, which began 13 years ago, had many partners. And this is really a bit of the local flavor for those of you who are here from British Columbia. So although the top part, you see the research colleagues, Judy, who leaves her name off of this, Dr. Lynham, who was the lead researcher, colleagues mostly from nursing. I was honored to be the one physician in this very strong nursing research group. August funders, partnerships with our school board, with the community, with the university, and with our health authorities. But it was the community who said, this is the first time that UBC hasn't come in and told us what they were going to do for us. They asked, what do you need? And when we first came, it was, our kids have the lowest score, the highest rates of vulnerability on the early developmental instrument. They are not ready for kindergarten. So our provincial average was around 28%. 70% of the kids in the inner city schools were not ready for kindergarten based on the HELP EDI instrument. And they say, we need help. We don't have, kids are aging out before they ever get into daycare, into supportive early intervention program. They're coming into kindergarten without any supports. Within 2 months of being there, we had 4 youth who attempted suicide, 2 that were completed. all of those kids had been in foster care. And we had to turn and be responsive and say, we're not only an early intervention, early child development responsive program, we're going to address the needs of youth. And so this morning you were beamed in by our youth health team, who very much wanted to hear Gilles and Helene, and they couldn't leave because of the high volume that we have. But we are a full service, not only 0 to 19, but our services go 0 to seniors, through seniors, because children live with families and families live in communities, and what the community told us is that they need care for their grandmother or their uncle who's living out in the van outside of the public housing. So that's really what we do here. The reason that we started was because of the high rates of poverty. We moved along, and by 2014, in conjunction with the Foundation Julien and the meetings that were done in partnership with Public Health Ontario, we have developed more of a Canadian research collaboration, and I'll share with you at the end some of our publications and the key findings from that collaboration. Again, I told you what the acronym stands for, but RICHER stands for Timely Responsive Access for Early Intervention and Prevention Services, to work collaboratively, intersectoral, meaning across sectors, and interdisciplinary, to improve health outcomes, not just outputs, not how many kids you see, but what are the outcomes, to use indicators like school completion and social capital through an equity and social determinants lens, and to plan for transition services for more vulnerable children. So, as I move along to, where is this? These are big Judy Lynam words, to explicate the processes and practices that dismantle structural and social barriers to healthcare access, which mean to really look at the systemic violence, the systemic racism, the barriers, the way, despite living in a publicly funded healthcare system, we have abysmal differences in health outcomes for new Canadians, for Indigenous Canadians, and for Canadians who have less access due to distance, more chronic illness, and may have different belief systems about health care. So we wanted to measure the effectiveness of a primary health care model. And what does a primary health care model mean when, as a pediatrician, I'm a specialist? I trained as a primary care provider, but in Canada, I'm seen as a specialist. So how do you get people who have all these years of training around children and child development and youth health, how do you get that to the community? How do you get that to primary care? And then how to put this in the context of real practice. So we chose a neighborhood that was within 7 kilometers of the Children's Hospital and 7 kilometers of our rehabilitation hospital. We recognize that we have a commitment to universal access, but that the services were not fairly distributed. So kids could not get in to see me as a specialist if I stayed in my specialist role. So the one big difference I would say between my Tuesday job when I'm at Children's and my Thursday job when I'm in the inner city is that it's your accessories. So change your shoes, folks. There's a view. And I just looked at Gilles and Helene's shoes today. We came as who we really are in the practice, that you're actually working with the community and you're working horizontally, as opposed to this view that my Children's Hospital is situated in one of the wealthiest neighborhoods in our country. Parking is horrible, and our families don't even have cars to be able to park there, but getting there by public transit is very difficult and can be very expensive. And it's more than that, it's the feeling that they don't belong. And so what we needed to do was bring the services to the community, and our practice model is to link in and link across. So our primary health care providers, who are like what you've heard about in Montreal, they are there in the community, in community spaces, in the school, in a clinic setting that's more like a living room. It's a renovated townhouse in a publicly funded former BC housing complex where families feel comfortable. We've demedicalized the environment. But then when families do have to be linked across to those specialist services, they get a warm handover and they get a warm pass back to the community. And the importance of listening to the community, and then when we talked about this setting being a place for the research, all research is vetted with the community. So any new idea comes to the table, and I'll explain what the table is. Social determinants of health, I'm in the green box, so a quarter of our health is related to access to health care and the kind of health care that you get. But the majority of our health is socially determined, social economic factors. My genetics and the environment where I live they are important. So all of the effective health care must attend to all of this. We do need to be concerned about global warming. I do have to acknowledge my genetics. We do need to have a strong publicly funded healthcare system, but if we're going to plan and we want to think about our future and our children as our future, we have to look at the social and economic factors. So the most important thing all of us can do, those of you who vote, is to consider who you're voting for and to make sure that you think about the importance of the child tax, the family child tax benefits, and that money is a prescription for health. So the evidence of our impact is that we have been able to measure that there was a critical difference in the vulnerability at school entry in our inner city schools. So we went from 70% to 50%. We're still higher than the provincial average, but the train at least stopped and turned around and started going in the other direction. We have research that shows that the model does foster access to quality primary and specialist services, that we have organizational structures that are accountable to the community and that were responsive, and that's where we talk about the community kitchen table, and I will explain what that is. You saw it in different forms as it was discussed in Montreal. We have a formal kitchen table every Thursday morning from 9 to 10. The doors are open. The rules are no acronyms. You know, this is a community table. We speak with each other. We talk about issues, not individuals. We take moments, not minutes. And we operate on trust, respect, and confidentiality. We've formed purposeful partnerships. And this is a Judy line I'm saying, a purposeful partnership. We work in partnerships, relationships matter, and that we are accountable, and that trust and parental empowerment are key parts of our model. So this is where our clinic sits. For the first 5 years, we weren't in a clinic. The community did not want us to build a bunker. They see public health as building these clinics, and then that's sort of where people operate out of. So as long as we stayed in the schools, all of our nurse practitioners have a weekly clinic in the schools. I have our pediatricians, they're distributed. I have funding for 1.5 full-time of a pediatrician that I share across 12 specialists and subspecialists. So we have a little piece stuck in place to support the primary health providers and other primary health providers in the community, and that we work in community spaces so that we're visible and accessible. So this is some of the research, and I think that this is something that should be a no-brainer, but how care is provided is instrumental. So what's the style of the interprofessional style or interpersonal style of patient empowerment? And I'm not joking about, your shoes, but it is about, some research said, the doctor comes in and, their shoes are my monthly income. Like it doesn't fit. So we dress to be respectful, but it's about a style. It's about, as you saw Dr. Julien, on the same eye level, and you're not amazed when families give you histories of what's happened. You sit and you listen quietly. That may not have been your journey, but you can appreciate their journey, and you're not judgmental. And I have to say that I have a daughter who's just finished nursing, and my mother was a nurse, and I think nursing training does a lot better job in relational practice and about working and developing a therapeutic relationship. And too often, as Tatiana said, those medical students would walk along and say, what's on the exam? And it's on the clipboard, and they don't know how to get down on the ground and play with the kids, or get to actually listen to families, to what matters to the families, what's the family's unspoken concern. This was just another slide showing this measurement of critical difference that they now calculate, showing that there was a difference. So anything in green is a good sign. So there are areas out here near UBC where things got worse over the period of time, and in the downtown east side, which is that green area with the area, things got better. We're still not doing as well as these wealthier areas, but we're at least addressing these inequities. The relationship style matters, and again, it's how important it is for you to be included in the decision making and treatment plans. How important is it for you to have a health provider that treats you as an equal? And this was something that gave my surgeons pause because I asked these questions. We've recently completed a survey of 600 families who come into my hospital, and I'll share a little bit of that with you at the end because it's new news, and it's quite, I think it's quite exciting to know what matters to families, and to realize that relationships matters, and that even our surgeons care about being social pediatricians. So we've worked to dismantle structural barriers, we've worked to dismantle social barriers, and to foster responsiveness. And I've mentioned the weekly community kitchen table. Trust is essential in this, and having the clinicians located in neighborhood settings, in spaces that access complementary services. This is the oh my God org. These are called logic models. But it gives you a bit of an idea if you see that little gathering. Oh, no, what's up there? Publications. This is the richer table. This is the richer organizational chart. Link in, link across. I realize I've been a slide ahead, a slide behind here. Equitable access, improved partnerships, being responsive, and being based on an equity model. If you look up Lynham, you'll find everything we've done. Just know how to spell Judy's name. If you want it, my name is somewhere in that mix with 2 O's in it. The last article, which dropped off the bottom, is the article that I wanted to share, this newest research with Ingrid Tyler, who's a young medical officer of health now in the Frasers dealing with the fentanyl epidemic. When she said, what am I going to do? I said, we did this with HIV. You'll figure it out. But the work that she did with Public Health Ontario in gathering together social pediatricians from across the country to look at what are the mechanisms for engagement with vulnerable families can be summarized into these demi-regularities or mechanisms. So the importance of sharing power and status. You saw that this morning as Hélène and Gilles talked about their model. You don't see someone on the top of the pyramid. You see the teams and the circles and the family, the child being in the center of a circle. So it's horizontal, that we bridge trust. So if there's a relationship with someone working in the community in the Women's Center, and the family trusts Wanda, and Wanda trusts Clea, and Clea trusts me, family may come in and say, Dr. Chris is going to be okay. But the importance of bridging trust and developing this social capital for families. The knowledge support is about the knowledge support for us. We all went to different kind of schools, So medicalese is different than legalese, is different than teacherese, is different than social workerese. And we use our language in different ways, and we have to learn how to train together. And when Dean Frank introduced this course, he told me that his last job was working with the Faculty of Medicine at Dalhousie. I said, we're doing this together. We have got to train together to work together. We have to have the knowledge support to work across our barriers. It's our silos. Families don't live in these silos. We're the ones that work in these silos. And then lastly, the last key mechanism, and this is about empowerment. And it's about empowerment of the families, and it's about empowerment of the communities. This is not a charity model. This is a model that you build on the existing strengths in the community, and you help those communities develop those structures to address the structural barriers and the inequities. So, and 2 weeks ago, now I said 3 weeks ago, in the Globe and Mail, there was a big piece by Dr. Michael Unger. He's the Canada Research Chair in Resiliency, and I get tired of people talking about kids he just needs to pull up his bootstraps, be strong, that resiliency is just intrinsic to the individual. You either have it or you don't. He said, put down your self-help books. Resiliency is not a do-it-yourself endeavor. The science of resilience is clear. Social, political, and natural environments in which we live are far more important to our health and fitness and finances and time management than our individuals' thoughts, feelings, or behaviors. When it comes to maintaining well-being and finding success, environments matter. In fact, they may matter just as much and likely more than the individual thoughts, feelings, or behaviors. And so it's all about relationships. A positive attitude may be required, but no positive attitude will help you survive a natural disaster, a bad workplace, or childhood abuse. relationships that nurture you, that allow you opportunities to use your talents in places where you experience community and government support and social justice matter. Once you have these, your world will help you succeed more than you can help yourself. And that's where we as citizens have to think about creating the scaffolding for the success for kids who have grown up in environments that were environments that have been set up in the past for them to fail. And so this last piece I just wanted to share with you rounds that I did at 7 a.m. on Tuesday morning with our surgeons. We called it Operationalizing Evidence to Dismantle Structural Barriers in Pediatric Care at our Children's Hospital. We, over the past year, with the help of 3 incredible medical students and the Office of Pediatric Surgical Innovation, we managed to listen to 600 families. We had a 30-item questionnaire where we used questions that were developed in the research with Dr. Lynham and colleagues and my poverty research colleagues to ask about the social barriers to their health. And the doctors of BC want us all to ask about ACEs, the adverse childhood experiences. And my colleagues all said, this will be traumatizing for children. You don't want to ask about these things. And what will we do if they report them? And so our hypothesis was, we can't do this. And I actually found that we actually can ask about adversity, and families say, thank you, thanks for caring. These things are happening in our lives, and you've taken the time this was a quality improvement study to know who was sitting in our waiting rooms. So the way we asked about ACEs is we didn't ask them face to face. We said, just tick off your cumulative number of ACEs. How many ACEs? And the key around the ACE is if you have 4 more ACEs in your deck, you are at higher risk of poorer adult health outcomes. And so in pediatrics, we need to do something about those adversities. Children shouldn't be living in environments of neglect, abuse. They shouldn't have parents who don't have access to mental health support. That they shouldn't be in places where they're witnessing violence and where there's neglect and lack of resources. So the results are that yes, with respect to social supports, these are 3 key points. Tatiana, I've got 2 minutes. Am I okay?
You're fine.
I'm good?
Yeah, 2.5.
Okay, 2.5. This was a big thing we asked, do you have a primary health provider? Because we started the downtown east side and none of the families had access to primary health care. What they had were walk-in clinics for ulcers, HIV, and addiction. There were not services that were oriented towards families. So families coming into our clinics to get specialized care I'm the medical director of a cleft palate program. We have a spina bifida program. These were the surgical clinics that have surgeons in them and general surgery clinics sitting there, waiting there. And they said, yes, the majority said they actually say they have a primary health provider, but a quarter of them said they can't turn to them for filling out disability forms, for being able to get forms to get medications, to get the items that they may need to help their child with extra needs. And a third of our families identified as a visual and cultural minority. It was interesting that the majority of the families that indicated that they had indigenous heritage did not tick off that they were a cultural minority. They see them part of mainstream society, but a significant number of the families that are seeking care at our hospital do have indigenous heritage, and they're not receiving benefits that they may be eligible for. With respect to economic adversity, I told you that in Canada it's 1 in 4 that kids live in poverty. In British Columbia it's 1 in 5, and in our clinics 1 in 6 of our families are below the low income cutoff line, and we didn't actually adjust for the number of people. So I have a few families that I personally work with who have 6 or 7 people in a 1-room dwelling in Surrey, and they're below $40,000. So we have deep poverty sitting in our very wealthy children's hospital. And when we ask, have you completed your tax forms, a significant number have not, and they're not getting the benefits that they should be eligible for. So it says that we need more support, more navigators to help families to support the economic barriers that they're facing. So this was just a nice graphic representation to show that at our children's hospital we have real poverty. About 1 in 4 families are sitting there and they're having trouble making ends meet. Coming to our clinics means they may lose their job, they may lose their income that day. We need to think about how we arrange our health services. With respect to ACEs, we're around the same. We're actually more than the U.S., which is, they say about 1 in 8 kids in the U.S. or families say they have had adverse childhood experiences, and our group, it's more like 1 in 6. About 16% have had ACEs. And there is, when we looked at an analysis of variance, I'll turn it the other way around. Wealth seems to buffer or hide adversity. So we do see an association with reported ACEs in a family's life and poverty. But I wouldn't want you to say that wealthy families don't have ACEs. They may have been able to do something about it, or they're not being honest when they fill out this anonymous questionnaire with us. And then lastly, this I took from earlier work when we were working to support women to not lose their children because of their substance use in pregnancy. And research at the University of Washington showed that women who continued to drink in pregnancy had less than 4 people to turn to. This is a very old social science research, and it stuck in my brain about who are these women that, they live with a partner who wants them to keep drinking. They've experienced severe ACEs, physical, sexual, emotional abuse in their childhood, and they have no access to mental health support, despite 1 in 4 of them having significant concurrent disorders. So I said, well, let's ask families if they have an adequate social network, and then let's give a number. And I was shocked at the number of our families that have less than 4 people to turn to. And it's in this one that we're looking at the analysis of variance. But when I looked through them, I did not see a relationship with wealth. So I have wealthy families who have no social capital, who are sitting in our children's hospital and they don't have anyone to put their other kids with when their child's having surgery. And we're not prepared. We shouldn't be dealing with this on the day of surgery. We need to know about this. We need to ask about these things. We need to build stronger primary health care so that families aren't coming in to a hospital. The hospital shouldn't be the place where we're trying to solve these social barriers. So, and then lastly, we ask family what matters to you. So on the podium, first is they'd like to know more about other families who have children with similar conditions. They'd like to know about eligibility for disability support, but sadly, they'd like to know how to pay for parking. And this is, I don't know that this happens in Quebec, but parking in this city is awful. And it is unfair, and I would hope that some of you know someone with a lot of money that could buy the parking lot at Children's Hospital so that families don't run out to pay for their parking and miss their appointments with their health providers because of the cost. These are real barriers for families. So remember 4s, that while the majority of our families they say they have primary health care access, 1 in 4 can't turn to them. Patients who don't believe they have a social network have fewer than 4 people they can turn to in times of stress. 1 in 4 of our families that come to our children's hospital, sitting in our waiting rooms, looking for specialist care, like somebody like me, are living below the poverty line. And 1 in 6 of our patients have a score of 4 or more on the ACEs. And only 1 in 4 families chose to skip that, so it wasn't traumatizing for them. What we realized is it was really literacy high, and some of our families couldn't read. It wasn't a multiple guess. That question was hard. And so when I actually would go through it with them personally, they had no trouble answering those questions. It's just the way we ask these questions we have to appreciate literacy. So ask about bears. Getting back to my 30-item questionnaire, we need to know about barriers. We need to know about the economic status, about ACEs, resiliency, and social capital. And if you would like to know about the resources, such as this lovely resource that my McGill student did, 4th year at McGill. You don't get to keep him. He's going to come back here and be a doctor. He mapped out that you can get a $2 meal at just a block from St. Paul's Hospital, and you can take the UBC shuttle that goes from Children's Hospital to St. Paul's Hospital. And so our families who can't afford to eat on our campus can get a healthy meal, a mere 11-minute ride, free ride away. So it's those kinds of resources. So I also learned something from him. If you'll hold your camera up to that, you don't have to take a picture of this, but this little bar, everybody pull out your camera and do this. It will link you to the Office of Pediatric Surgical Innovation and Enhancement, and you will get a list. Not only you'll get this talk and you'll get our questionnaire, and you'll get our poster, but you'll get the resources that we're developing with nursing for where to get food, where to get lodging, where mental health support. I tell you, let these youngsters get involved with projects, and you'll do it. So I learned something. I learned this on Tuesday morning. I'm still learning. So thank you all for letting me give you kind of a 13-year look at where we've started and how we're trying to now infiltrate the big mothership of institutions to recognize that the importance of social pediatrics is that we all do social pediatrics. Every one of us. You do not have to be a pediatrician. PED stands for child, and iatrics means to care for. I should end more eloquently, but I like this, and I was looking for the definition. So advocacy means to add a voice, and the Greek word for pediatrics, a child comes from the PED, and the iatros is healer, and healing doesn't only belong in the hands of health providers. So thank you all.
Chris, thanks a lot. So here's a suggestion. Because we will have a roundtable panel after the last presentation, I suggest we ask 3 questions which are so burning that we will put the whole university building on fire if we don't ask them. So, and after that, we'll let Chris relax a little. We will listen to the next presenter, Suzette, who's here. And then every presenter for the whole day will be right in front of you, and you'll let them answer all other questions which do not put the building immediately on fire, but might if we don't ask.
It's all on there, guys.
Yeah.
Everything I just said is all up there.
So, the last but not the least for today, and Suzette Nesborn, right?
Narbonne.
Narbonne. I'm so
That's
sorry.
okay.
Just unfortunate.
Suzette works.
And after I was always called Titania, Titanic, so I guess So Suzette is a lawyer who works for children, and we can say, I guess, in children's protection, protecting children's rights. Is that right?
Protecting children's rights.
Children's rights, yeah. And Suzette will share with us her story and what she's doing. And after that, as I said, we'll have a panel and you will ask all the questions possible.
Okay.
Please.
So what I'm actually going to do, because I was given completely free rein over my topic, is I'm going to talk to you about the state of the law with respect to children in British Columbia. And I will weave in stories about the work we're doing so you can see the contrast between what's happened traditionally and what happens when a lawyer gets involved. So I will give you a bit of a backdrop and we'll just take it from there. I work at the Child and Youth Legal Center. It's an initiative that's been around for almost 2 years now, and all of our work is really mirrored on the Convention on the Rights of the Child. So I will talk a lot about that. I have a bias. I think children should be represented when they want to be. And you're going to hear my bias, but you're also going to hear why I say that. So child representation isn't new. It's been around certainly as long ago as 1974. The Law Reform Commission of Canada said, where the interests of a child will be directly or indirectly affected by a court proceeding, consideration should be given to the appointment of independent legal counsel to represent the child. So this is back in the 70s. In 1989, the Convention on the Rights of the Child was adopted by the UN. Article 12 is the article that we primarily mirror our work on, Article 12 and Article 3, so I'll start with a bit about those. Article 12, a presenter, a professor named Nick Balla, who is the guru of family law, asserted that Article 12 is especially important because it's one of the few provisions in the Convention that actually provides for children's involvement. It's something where the children can actually exercise rights themselves, and they get to be involved in decision making that's going to impact on them. What Article 12 says is every child, or it assures to every child capable of forming his or her own views, the right to express those views freely in all matters affecting the child, the views of the child being given due weight in accordance with age and maturity. In particular, the child shall be afforded the right to be heard in any judicial or administrative proceeding affecting him or her. So putting that another way, we should respect the views of children and youth, and we should include children and youth in matters that are going to impact on them. The right of children to be taken seriously constitutes one of the fundamental values of the Convention. So in Canada, every single province and territory has a way for children's views to be heard in custody and access proceedings. In British Columbia, so our province, the court has to consider their views unless it would be inappropriate to do so. In our province, there's a variety of ways that children's views are heard. So there's things called Hear the Child reports, there's experts who interview children, there's judges who will meet with children. Sometimes the child's views come in from their parents testifying about what the child told them. And it runs a gamut right up to full representation for children. Notwithstanding the fact that the court's supposed to consider it, and notwithstanding the fact that there's numerous ways for the court to consider the child's views, the reality is that in less than half of the reported cases in Canada that deal with custody and access, do they even mention the views of the children. So they're supposed to consider it, but they don't even mention it. The prevailing view in our courts in British Columbia, and mostly across the province, is that the appointment of a lawyer for a child should almost never happen. So why does this matter? Why can't we work with this process? Well, when a decision's being made in a custody case or a child protection case, a child's life is going to be profoundly affected by that decision. Who they're going to live with, who they're going to associate with, where they're going to live, where they're going to go to school, sometimes whether they're even going to see their parents. All of these things are being decided for that child. You're not going to find it surprising that what the literature says is children feel powerless in these situations of family change. Suddenly they're finding themselves often with almost no information about what's going on in circumstances over which they have little control and absolutely no say. They want to know what's happening, and they want to be heard. They don't always want to decide, but they do want to be heard and understand how their views are going to be taken into account in the bigger picture. The Convention recognizes this, and its object isn't simply to protect children, it's to empower them. And I was thinking about that when Christine was speaking about empowerment is just so key. And I mean, I know I'm speaking to the converted, but it just makes sense that you empower the child. These are the people who are being affected. There's numerous paternalistic views. We hear, as lawyers, children don't know what's best for them. It's harmful for a child to expose them to the conflict. In my opinion, that's naive. These children are living this conflict. Where I'm working, we hear over and over again from children who say, my parents have been fighting about me for years and nobody cares what I think. So every province in this country has a different test on how and when a child can have representation in court. And British Columbia's test is far and away the most restrictive. So I will give you a bit of law, just to give you some context. Our Family Law Act says, before a child can have a lawyer to represent them in court, the conflict between the parents must be so severe that it significantly impairs the capacity of the parties to act in the best interests of the child. So that's the first part of the test. And the appointment of a lawyer must be necessary to protect the best interests of the child. So in other words, things have to be really bad. Why would we as a society say it's okay to wait until things are really, really bad before we bring in a lawyer? And I can tell you from my own personal experience, one of the problems with that is we're walking into a mess. The lines are drawn. Everyone hates everyone. The child is living this. And now we're trying to bring some sort of sanity to an insane situation. So even if a child gets through this really hard, high bar, and a judge says they can have a lawyer, the child in British Columbia isn't entitled to a legal aid lawyer. So who pays for the lawyer? The court can appoint, well, the court can divide the cost of the lawyer between the parents. But I can tell you from speaking with the very few lawyers who've done that kind of work, the lawyers never get paid because the parents don't want to pay for the lawyer. It's just part of the whole conflict piece. So their only other option really is our center. We have 3 lawyers. We're building a roster of lawyers throughout the province. It's a small roster. We do the entire province. In child protection legislation, and we do less of that, and I'll tell you why as I go along here, but in child protection legislation, there isn't even actually provision in that act for a lawyer for a child. Children can be added as an actual party to the case, and that is done through a section of the act that isn't, in my opinion, designed to add a child as a party to the case. It's a section that says the court may add any person as a party. So it isn't child-specific, and it certainly isn't child-centric. If a child is added, and that rarely happens, the Director of Child and Family Services, who is that child's guardian while the child is in care, decides whether or not to provide a lawyer. Now, some people think once a child's made a party, they get a lawyer, but that's not the case. They may get a lawyer. They may get a lawyer to explain their rights at this point, and that's it. They might get a lawyer to represent them through the trial. Yes and no. It's not through. It's through the ministry's budget. The ministry decides it may or may not be administered by LSS, but it's through the ministry's budget. Sorry. So, and I can tell you my coworker who can't be here, but who read over my paper, didn't know that once a child's made a party, they don't necessarily get a lawyer. Whether or not they get a lawyer in part can depend on, according to the director, whether the social worker can explain the child's preferences to the court. So this isn't to advocate for the child, and it's not to agree with the child. It's just, can the social worker adequately explain the child's views? Bernard Richard, who was the former representative of children and youth, said, in BC, lawyers are only ever rarely provided for children or youth in child protection or child custody matters, in complete violation of Canada's commitment to the principles of the Convention. So we'll contrast that with Ontario. In 2017, their child protection legislation had a complete overhaul, in part because of recommendations arising out of an inquest into the death of a child, which unfortunately is where most of our legislative changes happen in child protection. The Child, Youth and Family Services Act of Ontario has a preamble that says this: in furtherance of these principles, the Government of Ontario acknowledges that the aim of the Child, Youth and Family Services Act 2017 is to be consistent with and build upon the principles expressed in the United Nations Convention on the Rights of the Child. So they have modeled their child protection legislation on the convention. The Act further mandates that when the court's determining what is in the best interest of the child has a list, and the very first factor listed is the views of the child. So they're taking it seriously. In my view, Ontario is light years ahead of us when it comes certainly to their legislative framework and their representation for children. So what's the value in hearing a child's view? The reality is children and youth can give you really valuable insight into the issues that the court and their parents are grappling with. it's often difficult for the parents to understand this because they themselves are so enmeshed in the problems and they're going through their own emotional pain. Understanding the child's views can often lead to fruitful and lasting settlements. And I'll share with you a few stories as I go on from the work I've been doing, and we've been doing at the center. I've anonymized this quite a lot, but the stories are true. In one case, a child's parents were sharing parenting time of the young boy when a job opportunity came up for one parent, but it required the parent to move to another province. From the parent's perspective, the only issue was, where's our son going to live? The parent's history was one of endless fights in court. Since they're almost 5 years since they separated, every single decision about their child had up to that point been made by a judge and not by them. This trial respecting this potential move had been set for several days of court time. They had drawn their battle lines, and the child, of course, was experiencing the anger that the parents felt, the fear of not knowing what the outcome was going to be, and of how this was going to affect him. The one thing, and probably the first thing since their separation they actually agreed on, was the child should have a lawyer. And the reason for that was probably not very altruistic. They were positive that each of them was right about what that child wanted. And the lawyer's going to come in, is going to talk to the child, and going to prove me right. So they retained me. This might not surprise you, but the parents also said, we will respect our child's wishes. So this child met with me several times, and that's a really important piece of child representation. You don't meet the kid once and go off and say what they said. I see it when I look through my interview notes, how the relationship develops and how we come to plan, and I would never meet with a client once and go do a trial. Why would I do that for a child? And that's an aside, but I see it in child protection all the time where if a lawyer is appointed, they will go to court and they'll say, Your Honor, I've met with the child once and this is what they tell me. And I'm like, are you kidding? You are seriously feeling that's representation? So this child meets with me several times and his views were far more nuanced than do I want to move. Through me as his voice, he was able to explain ultimately to his parents what he wanted and the reasons behind what he wanted. And what the parents got was some real insight into his emotional needs, his social needs, a number of things. And although the views were not what either parent had expected, they ultimately decided they would in fact respect their son's wishes. And it was quite interesting because one of the parents, when I told them the wishes at the trial, said, well, no. And then thought more about it and came up to me and said, you know, I said I would respect his wishes, and I'm going to. It was super empowering for the child, and it really helped both parents. And this marked for this family the very first time they left a courtroom with a decision they had made and not a judge had made. Since that time, because the problem with being a children's lawyer is you never close a file. So since that time, they continue to cooperate with respect to their son. And his life is better, and their lives are better. The judge in that case, just as an aside, told my husband that he owes me a bottle of wine. So I'm waiting for it. I prefer red if anyone wants to know. Now, Article 3 of the Convention is the other piece I spoke about. Article 3 requires, in all actions concerning children, whether undertaken by public or private social welfare institutions, courts of law, administrative authorities, or legislative bodies, the best interests of the child shall be a primary consideration. And then according to the UN Committee on the Rights of the Child, they say there is a direct link between legal representation and the best interests of a child. Just to give you some background, I guess, which is something I've learned through the course of my work. After this convention was signed, there's a committee that meets regularly to ensure that the states who are signatories are actually compliant with what they have signed on to. And to that end, this committee publishes general comments. In general, the comment that comments on the relationship between legal representation and protection of the child's best interests, it says, The child will need appropriate legal representation when his or her best interests are being formally assessed and determined by courts or equivalent bodies. In particular, in cases where a child is referred to an administrative or judicial procedure involving the determination of his or her best interests, he or she should be provided with a legal representative in addition to a guardian or representative of his or her views where there is a potential conflict between the parties in the decision. So what this means is hearing the views isn't enough. A legal representative is in addition to someone who represents the child's views anytime there's any potential conflict between the parties in the decision. So if you look at child protection proceedings, the parties are the state on the one hand and the parents on the other hand. The state may be seeking to take guardianship from the parents temporarily or permanently. The child's best interests are the thing that is front and center, notwithstanding these are the parties. Having a social worker, even a really well-meaning social worker, explain the child's views to the court isn't compliance with the convention. And if you take a family law custody and access dispute, in that case the parties are usually the parents. And again, the child's interests are front and center. So clearly, in my view, the sheer fact that these parents are asking a judge to decide their child's fate highlights the fact there's a conflict between the parties. Just to retain a professional to speak with the child and present the child's views is not enough. According to the convention, the child is entitled to a representative of his views, that's the professional, and a legal representative to make sure the views are heard and considered, that's the lawyer. If you juxtapose the language of the potential of conflict from the general comments with the language in the FLA, which requires, and you'll remember back there I said not potential conflict, but conflict that is so severe that it significantly impairs the ability of the parents to act, well, clearly these don't match up. The language of the Family Law Act doesn't conform with the expectations of the Convention on the Rights of the Child. And the authors and the people who have said we're not conforming are right. We have to start with the understanding that children are rights holders. They are entitled to the same protection as everyone else is with respect to their rights. So what should child representation look like? It has to be transparent. It needs to be informative. Children should have full, honest, age-appropriate information about their right to express their views freely. They need to know as well how this participation is going to take place, what its scope is, what its purpose is, and what its impact might be. So what happens right now in British Columbia? Child participation often looks like this. Court orders a report to determine the child's views. A professional is retained to speak with the child. An appointment is scheduled and the child is taken to that appointment. The professional sits down, they talk to the child, they find out their views. Sounds great, except the child has no context. Children have told us they often don't even know they're going to do this day. They don't realize that they're about to exercise their one and only opportunity to freely express their views. They don't have information about what's going on in the court because we want to protect them from that. We don't want to draw them into the conflict. This meeting that they have is not a privileged, confidential one, and they might never see that professional again. Their views will be recorded, often word for word, and then there might be a brief follow-up conversation by phone just to confirm that this is what they said, that the professional got it right. And I can tell you, in my representation of children, I would never tell them what they told me. I don't ask leading questions. I let them tell me things. I would never ask a child leading questions. I would never say, in our last interview, you said blah, 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 blah. I would ask them about things, and I'll even say to them, I do listen to you. Some of the stuff I'm asking, you're going to say, I told her that already. But I will explain to them that I really want to allow them to speak, and so I would never do that. But in a Views of the Child report, the author will often, and I don't want you to leave here thinking I have a problem with the work these people do, because I don't. I think It's one piece, it's not the only piece. But they will often just read to the child, this is what you said, is that accurate? And they'll write it down and they'll provide the report to people. So then that report is released and it goes to the parties and to the judge. And that's if that child's lucky. If the child's not so lucky, an evaluative report is ordered. In that case, the professional sits down, listens to the child, and decides whether or not the court should give that child's views any weight at all. Unlike the child, this evaluator has full context. They've spoken to everyone. They've seen reports. They've done tests. They've done it all. So again, there's nothing wrong with knowing in a very broad way what's in the child's best interest. But why wouldn't we give the child that same protection? Why wouldn't we allow the child to know what's going on? This is the context, so that when they're making decisions, they're making real decisions. It's their future we're talking about. The other problem with the reports, in my view, is the children aren't told that the report's about to be released. So in another case that we saw, the report had been released. The child had no idea. Parent got the report, went to pick up the child to exercise his parenting time, was so angry about what the child had said that he sat the child down in the car and forced her to retract her views in writing. He then took her view and filed that with the court. This process completely devalued her views. It made her look like she didn't know what she wanted. From her perspective, she was defeated. She learned that her right to freely express her views was subject to her parents' approval. The other piece about reports is once a report is done, it could take months or years to get your trial heard. These reports can be dated. They might not reflect how the child feels now. How can that possibly be characterized as consideration of a child's views? So if you contrast that with a situation where a child has a lawyer, child meets with the lawyer several times. Often they find out for the first time. I don't know how many times I told a child what the court order says, because they don't even know. So they'll find out what the court order requires their parents to do, which is really what the parents are often going to have the child do. They learn what options there are, what the challenges there are, and they get some context. The meeting is privileged. And I really can't emphasize enough how important that is, because it gives that child the opportunity to express their views freely and in confidence, to make informed decisions with the benefit of legal advice. Yeah?
Just a quick question. When it comes to the duty to report, do you explain that to them?
I do not have a duty to report as a lawyer. And what she's asked, I don't know if everyone knows, but in British Columbia, if a child tells you something, you'll probably phrase it better than I would, but if a child tells you something that causes you to believe that a child in British Columbia is in need of protection, you are obliged by law to report. If you actually read the subsection on that, lawyers do not have that duty. It is a truly confidential meeting. Just so you know, I have never come across a case where I even felt it was a problem. These children have reported. No one listens to them. But when they get to speak to a lawyer, they also have the right to change their minds. They also can work through their feelings of divided loyalty in a safe environment. And another significant piece is I'm going to work with them until the case is done. So their views and their perspectives have an immediacy that helps to really inform the process. The other piece is they have the right not to express their views, and they come to learn that. So in another case that we were involved in, the person's parents wanted to decide what school this child was going to attend. This decision was going to determine where the child lived and which parent she would end up spending most of her time with. The parents couldn't agree on it, so they decided to let the child decide with the help of a lawyer. At first, the child was very flattered. She felt she was being heard and she was being respected, and she would come in and she'd meet with her lawyer, and space was made to talk about the issues that she saw as relevant to her decision. She also at the same time got some understanding of her parents' challenges. After many meetings, she decided she did not want to decide. Through the process, her needs and her concerns were highlighted, and she asked me to make sure that whatever decision her parents made, they knew what her needs were and they knew what her concerns were. When the parents understood what she needed and what was important to her, they were able to make the decision. And again, we avoided a trial. This child was so relieved because she didn't have to choose between her parents. And the parents were relieved because the child didn't reject them. Children's views are entitled to be respected. They should be voluntary. And I can't emphasize enough, the right to freely express your view means a right to freely not express a view. The process itself has to be child-friendly in order to ensure the child has the confidence and the opportunity to actually express their views when they want to. Children, the right to be heard isn't without risk, and children even who come to see us will develop safety plans around when we can tell their parents certain things. They can sometimes delay sharing information. None of that happens if you take away the lawyer from the equation. When a report is just released, a child can come home and find out the report was released, and the child will have never even seen the report. A lawyer's job is to represent what the child's views are and not to substitute our own views for what we think the child should want or what we think is best for them. The child has a right to be advocated for, and the lawyer's role will fulfill that. In my view, this allows for accountability. It allows the child to know how their views are being interpreted. It allows the children to have the opportunity to challenge evidence and to influence the analysis that will lead to the final decision. The children should also know how a decision was reached and what considerations the judge thought about. They should have a lawyer who can appeal decisions when they are wrong. And how could that not be in a child's best interests? We settle most of our cases, and we only represent children in high conflict cases. The sheer fact of the lawyer who is seen by the parents as independent seems to really help. But not all cases will be settled, and having a lawyer through the process will keep that spotlight on the child. I'm going to end what I have to say here with a comment from one of the staff from our center. A lot of our staff are here today, and they play a huge role in the work we do, but they very seldom get the opportunity to actually see the work outside of the office. In this case, one of the staff went to court and sent us her observations. It was really great seeing our lawyer in court today, listening to her references, multiple case law, instructions from the children. I noticed how the parents kept it about themselves, their rights, their health, their desires, and addressed unnecessary, irrelevant arguments. But the decision that is going to be made is going to affect the children the most. Yet no one made it about the children. I can't imagine what it would have been like without our involvement. The only person that put the focus on the children, voiced their concerns and rights, was our lawyer. She was their voice. I know our services are important and needed. I know a lot of work goes into representing these children. Getting outside of the office and being able to attend court and seeing how it all plays out is very eye-opening and rewarding. Children have the right to be heard and have access to all the tools that are necessary to make that happen. As the Ontario Court of Appeal recently said, one of the most significant developments in family litigation affecting children is the recognition that the child has a voice. And in my view, as a society as a whole, we are responsible to make sure that that voice is not muzzled. So thank you.
I want to ask, and the same from the presenters.
It's not
Julie,
better over there.
feel free to ask.
There's two here, it's up here better.
Sure, Jane.
The fan is bad over there too.
There's a mic. Yeah, there is.
That they could use.
Sure.
Yes.
It's easier for all of us.
This just came in at noon. If anybody's having problems here, we can use this.
Michael, thank you very much. I mean, the generosity of IT and reporting services is incredible. I mean, he's coming like an hour early every day to set everything.
Thanks.
So, okay,
She had a question.
yes, please.
Yeah, I just wondered about recruitment of roster lawyers for children and whether there's a process to ensure they're, able to developmentally explain things, those kind of.
Okay. Well, you could ask Caroline, who's right behind you, who's on our roster. We require, well, if you make the roster, you have to have a criminal record check. But to get on our roster, there's a fairly rigorous process of reviewing a resume. There's an interview with a couple of the people at the center. We explore those lawyers' child-friendly practices in terms of their interview skills and how they approach representation of children or communication with children. There's reference checks, so there's all that sort of thing. And then we have specific requirements on how you represent children, and they sign off on that. So that's what we're doing. We're working on a course. It's been somewhat delayed. The other thing I would like to say, because you asked, is the ministry doesn't have any of this.
I had a follow-up question.
I have a comment on that. I think that Suzette's work is doing is really great, and I wish we had this in Quebec, because it's not just the right to have a lawyer in Quebec. They do have lawyers when they use protection, but it's written law. And if you have a lawyer, it's because your case is brought on, your file is on my desk as a lawyer. But if your file is not on my desk, I'm not representing you. So children are left thinking they do have representation, but they don't have a lawyer until their file is on the desk. But the second thing is, if the child has a right to a lawyer, it's not enough. The lawyers must be trained to understand the child's development, trained to understand the children's right. It doesn't mean because you are a lawyer that represents the child that you're knowledgeable. And this other, and what we're doing in Montreal is we are training, we're developing an e-learning for within McGill's family medicine, including the Faculty of Law and the School of Social Work, so that they have the same training and that they speak the same language, so that we can work with children afterwards. So just having a lawyer is not enough.
One of the things that Suzette said that I just wanted to add, that some kids I work with are in situations where they love their parents, but they can't live with them. And if you verbatim say what you said, Korczak said kids have the right to secrets, have a right to privacy, and they don't need to be outed for the fact that they recognize their parents' mental health or addiction is just too great a barrier for them. They love their parents, but they may not be able to live with them. So it's the judgment of, I think you have to think about the child's, not what Korczak said, a child is present, is a human now, not a human later, and how they're represented. And I think that that's the trust aspect. And from a healthcare standpoint, we have a little trouble giving kids over because it's been an adversarial system, and it's usually never not been a positive experience for kids. It's been a tug of war, and they're the ones that are torn apart. I think we need to train together.
And Korczak himself had a father who had a mental disease. So Korczak felt it very thoroughly what it means to love your father dearly, but at the same time knowing that's a mad man. Yeah, how you deal with badness. Yeah.
You had a follow-up.
Yeah, and it's a bit legalese. I'm just wondering if you take a position of like amicus curiae, or if you take a different kind of.
What she's asking about is there's different models of representation for children. So if you're amicus, you are basically you're the lawyer for the court to help the court understand the child's needs. And our practice isn't. I'm not saying it's our view. Well, it's my view I'll speak for myself. It's my view that a child has a right to have their views represented. It does mean that we have barriers to representation, because if you can't instruct a lawyer, you can't have a lawyer. So there's a role for advocates, it's just not one we've taken on. In a much better system, in a well-funded system, we would have multiple roles.
Hi, I'm Alicia, and I'm working with Judy Lynham for the circle, evaluating the circle eventually here. And something that's come up a lot is the tension between Indigenous rights and child rights. And I'm wondering if you guys have experienced that in Montreal, that there's a tension between maybe that the child's wishes are maybe not in line with what the family wants in terms of cultural continuity, when thinking about the history of residential schools and intergenerational trauma and so on. I'm just wondering if you guys have had experience of that and how you've navigated that.
So
No.
repatriating kids
We
that don't
haven't-
want to be
We
repatriated.
haven't specifically like that, but it's not only for Aboriginal people. Like anywhere where you have different cultures and a gap in the culture, then you would have that. And I will let Gilles speak about it because he has more experience with the gap.
Well, in Codinège, where we have a site for years now, we're dealing with a lot of different cultures, probably around 200 different cultures. So we often have kind of gap because we all know that the first generation after migration and the second generation is another gap, which is very important. We often were faced with children on second generation joining street gang, which is not in the value of any culture. But they want to be identified to some group because they kind of lose. It's very difficult, in fact, from one generation to the other, to fill the gap of identity because of the strong influence of the welcome country on them. The older people, the parents usually will keep with their culture very strongly, and we have ghettos of different culture, even in Montreal, some part of Montreal. But when the new generation comes, they're faced with another culture which allow a lot of things, which is less rigid. And we have that gap to try to fill up. And it's not easy, it's always difficult. You experience some circle like that. And there's no answer, but from one case to the other, we try to fill that gap to a certain extent because we agree that these people have good values, like people from North Africa. They're very close to their children for a long time. They bottle feed the baby for many years. The kids sleep with the parents, for years. Usually in our society we disagree with that because of insecure attachment, what kind of possibility that could arise that affect children. But we're trying to usually we would agree if a mother say, my son still sleep with me and he's 5 years old or 6 years old, I would say, no, it's bad, it's dangerous for your child. We're just negotiating and mediating, and if the child is effectively immature, then we'll talk of immaturity, and the child needs some fresh air, could join a daycare, things like that, but we'll never go by judgment. I think the most important thing is not to judge any value, any attitude of society, mainly when they're joining our society, because then the idea is we're just do with the same as we did with native children. We'll just try to integrate them by forces necessary, which is always bad. So that's not a clear answer, but there's no, it's difficult. You just respect the value of other cultures.
Yeah, but to answer your question, yeah, I have cases like that, but I don't see it like that. Yes, the child has a right, but he also has obligations. And when we do a circle, it's not like the child is the king and, you know, he's part of the circle. So he has to understand different point of views, you know, and the circle brings a consensus. And I think one circle has been broken, but most of them has been a consensus. So to answer your question, I don't even see the problem in it. Because the idea of a circle comes from the Aboriginal philosophy, and it leads to the consensus. So the child is part of the consensus.
Chris?
I think what Alicia's maybe more acute in the Western provinces, or shows my lack of knowledge of Quebec and the cultural continuity, but we have kids here who've been raised by grandparents and residential schools and fled, and if they have no one, but they have their identity is actually in, they have people in their circle, and the idea is to repatriate them in another province with people that they don't know who are blood relatives, but they identify themselves more as urban Vancouver, not on reserve Saskatchewan, and there's a struggle about hearing the voice. At what age? Are you 14? Are you 16? You get to make that decision. And how do we not? It isn't an easy. It really does. You really have to listen to the youth and their capacity, and can they show that they have enough family here, and that they won't lose what was in, is their cultural right to still have the identity of their status, even though they never spent any time on that reserve in their life. But so the cultural continuity it's a conflict, and I think it takes a long discussion. We're going through one right now with kids I've cared for many years, and I think we have to go as slowly as possible to let them stay and finish school here. But I don't know. Carolyn may be thinking on that case. Anyway.
I wanted to add to this. Many years ago, an elementary school teacher shared with me, she gave children a home assignment, draw, do you hear me without the mic or?
It's easier with them.
Okay, so to draw a family, draw your own family. And all of a sudden, the kid who was always obedient and nice and well-behaved came to school and said, I don't want it. Why would you ask? And long after she learned about how broken the family was, and when you give a child just a very simple thing to do, and you assume as an adult who had a family, and the family was fine, and you assume that it's so easy for a child to draw a picture of your own family. And then all of a sudden there's a huge tragedy coming right there. So it's tricky and it's very subtle, and we need really to be tuned to every child. And what Korczak was talking about, a smile, a cough, nausea, whatever sign is a symptom of something. If you say a child is uneasy, uncomfortable with whatever you suggest, all of a sudden the child who's always been with you, then something is wrong. That means you are doing something wrong as an educator or a doctor or whatever. Yes, please, more questions. Yeah.
Mostly a question for the two lawyers, picking up on something that Chris said about sending people off into an adversarial context. Can you guys talk a little bit about working in a collaborative setting in an adversarial system, and talk a bit about the tension there?
And how long do we have for this?
curious, you know.
2.5 minutes.
Yeah, curious what you might say to
Hour, 2.5. Hour, 2.5. I do it all the time, right? I do it all the time because the nature of my work, it's nothing but high conflict. So what I try to do is to build consensus over things we can build consensus on, and to express the child's views in a non-judgmental way, because that's what I'm doing. I find that helps. I don't let myself get dragged into the drama that the parents are experiencing. I let Susan do that. Really, I let my role be to try and facilitate a conversation and to move forward. Every one of these examples I've given you were super, super, super high conflict, where I was able to sit down with the parents and help them resolve it. And it was really by being non-judgmental. I kept bringing it back to the kid. Kept bringing it back over and over again.
That's a really good question, you know, because the reason why I did the circle is that exactly this, because I don't think the accusational system, the adversary system is the right forum to solve family issues and children's life, based on children's rights. So I did a circle where it's non-adversarial. It's more friendly, and children are more at ease. It's not easy. It's very tense in the beginning until you start working on the strength. And you know, if you follow a process, then the tensions are right there. When they all come in, it's adversary, because you got this protection. You got all those people that are telling you what to do, and that you don't want to do because you don't understand your life. And then you have this child, and yes, you know, the case that you mentioned, children, community wanting to have their children back, they have been stolen from them. So the community is hurting, and they have been given power to have youth protection, to take the role of youth protection. But they are healing. And in the same time, they force children back, but there's process for that. And in communities, they do have also circles. And I think it would be a good idea to have, in this case, a circle. Otherwise, what will happen is that this little girl will fly away, you know, and she's not going to be respected, and the community will not understand, because everybody's right. But you have to come to a consensus, like you said.
Yeah, your question, I'm sorry, I didn't catch it. Yeah, please.
I just want to make a point about assumptions and about the cultural underpinnings in the law. We talk about the best interests of the child in the FLA, Family Law Act, and in the Article 3 is about the best interests of the child. But the idea of the best interests of the child in our law is a colonial structure. Those best interests are not what other people and Indigenous people would agree with as best interests of the child. So it sounds really great, but what does it mean, right?
And who decides?
And who decides? So if we have the judges, lawyers coming into it from their training as all of this, but we're going to put the best interest of the child first, it goes much deeper than that. What does it actually mean? So I would like to point you all to a paper by Ardith Wacham, who's done a recent analysis of that, what that means to Indigenous people. She takes issue with what best interest of the child means in Western law, and defines how it's different for
If you
Indigenous law.
can probably email it to me, I will be able to share with the students
that,
if
yeah.
you're okay with that. Yeah?
Ardith was also
Yeah.
one of our speakers at the scholars of the speaker series for Korczak here. She spoke 2 years ago very eloquently about.
Yeah. I'm a lawyer with the Continuing Legal Education Society, so my work is to train lawyers, and I do all the programming in Indigenous law and access to justice for children. And Ardith Wacham is the chairperson of our Truth and Reconciliation Action Committee for the society, and also the co-chair of the Indigenous Laws Conference every 2 years. And and you should also know while I'm talking, I must tell you, our work is to train lawyers, but UBC professors all get 2 courses free a year to come. Actually, it's judges that get 2. I think professors can come free as many as they like. I said so. So, right, Ron?
Right.
Right. And UBC students also. So just contact me, or just, my name's Teresa Schubert. But if you just call customer service at CLEDC, you can come, you can attend by webinar or in person.
But again, Teresa, if you can
courses.
share this.
Yes,
I will
I'll do
share
that.
it with
Because
you
the
and-
courses are, if anything you want to know about how lawyers are involved, you can pick and choose from the different modules in the course. You don't have to attend the whole thing. But if you're interested in family law, child protection law, indigenous law, and how do lawyers actually work within that, that's one way you can
That's
find
great.
out. And it's free, so
Yeah.
take
Yeah.
advantage of it.
Amida, yeah, you have a question?
No, but just wanted to-
Oh. Okay, question.
And this is a little bit, again, legally BC context. With the changes to the Child, Family and Community Services Act, where communities can be a party to proceedings, but yet children can't yet. They can, but it's very difficult. I just wondered how that might add to the length of time it takes to make decisions in the court system and look at that piece, because it ties into that collective rights versus individual rights, sometimes conflicting.
I don't always think adding someone lengthens the time. I actually think sometimes adding someone can shorten the time, because there's a lot of there's pieces in that legislation with mediation and group conferencing, and there's all kinds of which I assume are still going to be in the new legislation. So, because I can tell you, like, as a children's lawyer, oh, don't add another lawyer to the room, but it's not true that it extends the time. So I don't worry as much about that, and there are charter protected rights to trial within a reasonable time. With respect to child protection, at least there's Court of Appeal decisions on that from other provinces, which may or may not always work well, because sometimes families need some time to heal, and if you push this too fast, nobody heals. So I have my own personal views about the speed and whether you always want to move really rapidly. That's my view.
Okay, Jane?
Well, I wanted to start by thanking you all very much for the presentations. As somebody who's essentially a citizen who doesn't work in any of your fields, I found it incredibly inspiring. And I guess my question is, given that we have had a shift in the last couple of years in our government in British Columbia, is there any movement to get more of the policies or the laws in place to have more of what you're talking about in terms of integration and being child-centered, both or more dealing more holistically with and bringing medical, legal, educational together? Is there movement? I mean, is there movement within the AG's department to change the whichever laws would need to be changed so that it would be more in line with what you talked about with the declaration?
You answered that, yes. I know what you're going to say.
Not so much. So the representative had asked for some legislative changes or regulatory changes just to allow us to advocate for young people leaving care. The AG was the only department that decided that we didn't have that we shouldn't be able to, in terms of that it wasn't our right as the body or the office to ask for that. But it was actually the select standing committees of legal stuff. But no, I would say no. Also because of the fiscal climate right now, everything is getting stayed exactly where it is despite needs going on. But that's just my own personal opinion, not the opinion of the representatives.
So there's another view is when there's a crisis, the big crisis now, I alluded to it with the fentanyl crisis. You know, we're losing, we've had 50 airplane jumbo jets go down in Canada to the number of deaths we've had from fentanyl in our country. So, you know, when you think about the deaths, it's 3 or 4 a year in British Columbia, that we would, you know, we'd be changing everything if we counted the people who were dying from fentanyl. And just recently, as of last week, there was this big case about the youth and what I would say our duty to care. They're fighting over what's called secure care, and kids' infant act and their, you know, and their ability to consent for health care. And what's happening on the ground level is we have a duty to care for these kids. It's not about it's not the Mental Health Act and incapacity. It's about, we need to have services to support the root causes of why these kids have fentanyl, and their fear of systems and not having those safe places in families and things, so that there's a pushback. And the irony for me is it's wealthy families who, you know, get in the paper, but the kids that are most at risk are the kids whose families aren't able to advocate. So when I just saw this morning that there's something new, the new release on the new Ministry for Mental Health and Addiction, and the opportunity, I think, and a mandate that we have a duty to care for kids, and it means to hear their voice. Their voices that they don't want to be living on the streets, and they're not doing drugs. There's a reason why they're doing drugs, and we haven't addressed their distress. And so I think we've solved this with HIV. You know, we looked at the root causes, and you know, the drug is the symptom. And so I'm hopeful that with this crisis that we're actually going to we're going to have to work together.
I'm from Quebec, and I really look up at BC. Yeah. First, for a number of reasons. I believe in BC I have an open mind towards new ideas. So, for instance, in the 80s, you had Jerry McHale, who was working with the Attorney General, and he, with a group of people, Andrea Clark, and they developed a model which is based on mediation, children's mediation, protection mediation. I don't know if it's still going on.
We still have that process.
But the only thing I would criticize is that it would have been children 12 years old and older. So that point, I said to Jerry, I didn't agree, and the children can participate with the help. The first thing that I've done when I was creating the circle, I was creating the circle with a number of people, and because we never work alone, we want to do things, and the youth protection was involved. And I think when you want to change something, you need to bring on board those people. And I don't know if it's been done here, but it's just more powerful when the people that have the power, they join you, so that because they're not really happy necessarily with what's going on in their big organization. And they are looking for options. My option, I looked at BC.
We did meet with the AG. He was a new AG. We were a new program.
Yeah.
And he was definitely interested. And I think you have to build those relationships, and we're building them with the courts too. You need influential people to be influential, right? So our plan is to meet with him again. I think it's important to build that relationship. At the same time, we use the hard approach too, and if we find the right case, we're going to take it on constitutionally. So it's sort of a two-pronged approach, but that's what we're doing. And he did invite us. He was very interested in our program. He talked about it and encouraged us to come and see him again. So we're going to.
So general public writing and saying, hey, I just was out of you don't know me, but
Yeah.
I'm a constituent, and I was at this presentation, and I was deeply moved, and I thought you'd be interested.
Absolutely.
Yeah, and don't forget, BC is a pioneer for Korczak Association, for the Summer Institute. Don't forget that. No one is doing it, right? So,
We did used to have legal representation for children.
I know.
Until 2002.
No surprise.
So there was legal representation, it's just
Yeah.
got repealed with the Representatives Act.
Yes.
I just want to mention that at least over the years we succeeded in involving the government to support integrating services like medical, legal, and social. In the past 5 years now, they finance the development of new community pediatric centers in the province. We're up to 40, 42 or something. And it's partly financed by the government. So they're wishing to integrate.
Yeah.
Okay? So that's possible that some government, even though we have a conservative government now, and we don't know really what will be going on because there's a big crisis with youth protection because some kids died and were maltreated in foster home. And they're kind of, in the paper we see that it's turning to the right a lot, punishing parents. And even one journalist said, parents should get a license to raise children. So it's very fragile.
Yeah.
But again, we have the government to get involved in our way of doing things integrated, but also the private sector. We frequently, I keep saying when I come to Vancouver, there's so much money here. The private sector should get involved in projects like that, and they're wishing to do something. So you need to address not only governments, but how to pay the lawyers, private sectors. And it's very interesting because we developed the circle with some foundation, and then developed that through money from the foundation, but we are
Power Corporation, McConnell, and others.
huge organization, and some rich people also who finance the development of community social pediatric. So both government and private sector should be involved.
More than that. More than that. We talk about children's rights. Children can also write, and they help. I just give you an example. I can talk about the case because the case has been written it's a case law. The Barline case is an immigration. That family came to Quebec, and then after a few years, the child was in the immigration world. It was too heavy a load for the state, so the family was asked to return, but they had been anchored in Quebec. So those two children, they were asked to be leaving, to just quit their family, not the family, but their friends, their school, all the network they have developed, because the state had decided, the medical doctors had decided with the guy that there was too heavy a load for this girl. So they went to the federal court of appeal, and they lost. So they come to jail. It's okay, because he had been following one of the girl, and there's nothing much we could do, right? Federal court. So I looked around, and then the eldest girl, she was standing on the back, and I said, how come she hasn't been involved in that discussion? It's her life. So I invited her, and I taught her her rights, and I said, why don't you write to the Ministry of Immigration, Canada, and Quebec? She was 11 years old. So she wrote. And I also wrote a letter with Jill, and Jill signed it, and we sent both letters to both ministries. They are still in Quebec. And a few years later, not too long ago, that's been a long time, a few years ago, I met with the former Ministry of Quebec, and she said, you know, I remember that case. And it's not Dr. Julien's letter that made me change my mind. It's that girl's letter. You know, so remember the children, they can change their world, and they can write to the ministry. They can ask for changes. And this is much more powerful than adults.
I have a question about integration of different fields into one circle of support of a child. In my world of education, I know the worst part is to bring medical doctors or legal professionals to the conference on education. You can bring anyone anywhere, but they look at the program and they say, yeah, you know, yeah, it's interesting, yeah, sure, it's very interesting, but, you know, it's not my field, why should I go? So I'm thinking, overall, the concept of bringing people from different fields working for the same goal, which is a child, which is the future, is, in my experience, the most difficult part. Like, everyone in his or her own field is doing the best they can, they say, and many do. But when it comes to integration and cooperation with other fields, it feels like every part considers, okay, my part is most important, why should I really bother and spend time, which is always precious. So did you have this feeling like this? Am I clear or not?
It is, I mean, you're okay, it's really difficult. And even in medicine, when I started working differently years ago, I was kind of targeted as
Heretic.
heretic, or
Right,
not
right.
a real doctor, or he's just a psychologist or just a sociologist. He's probably not a doctor. I went through that for years. And we did persist anyway, because that's the way we wanted to work. Just to make it short, recently the president of the Federation of the Specialist Doctors called and said, I want to meet you. She never ever even said hello to me to some meetings or anything like that. Suddenly she decided that she wanted to meet. So I said, okay, you come to my place. And she came, and she's becoming more and more involved. She was very surprised, and she discovered that years ago. Long after we started that, that's probably a good new paradigm of medicine for the millennium morbidities that we talked about this morning. So with patients you're going to get there, but when you're too much out of the box, you're not anymore in the system.
Right.
And you need time to show that what you're doing is the right thing. But you should be patient, and they all come at some time. So don't worry.
Yeah.
Right. I presented my take-home points are the 4 mechanisms or irregularities, reviewing 17,000 or something research abstracts about how you interface in social pediatrics or vulnerable populations. 2 of those were family-centered, which had to do with empowerment and bridging trust. And 2 of them are directly to us, which is our willingness to work horizontally to share power and status and interprofessional training and practice. And when I talked to the dean a few days ago, and he said, the problem we had is that, you put people together and you've already socialized medical students, of which I was one. You have to be the first one to answer the question. You have to know everything. You have to memorize everything. You got to get it right. Or the students that weren't playing with the children, they were looking, what's on the test. And you really have to unravel the way we were trained and continue to unravel the way we're trained, because so what's been for me to have my surgeons lead that we care about these things, where I feel I'm working in an institution that's still really thinking about levels of evidence and building, big temples with big fancy machines and raising money for cancer, and those are important, but we're actually not looking at, are we a really family-friendly place? So I think that you have to look for friends in all kinds of places, and you have to be willing to untrain yourself on what was considered necessary to practice in your profession, and share power and status, work horizontally, and do this. I mean, just sit here and to call each other out and feel comfortable, like to develop trust with each other and do this way instead of behind your back about what's wrong.
Yeah, I was about to say, that's why we're here.
It's really important.
Yes.
That's interesting. And well, the ACE study that you mentioned in your lecture, Chris, is very interesting because it's really one of the first time we discovered in medicine that adverse trauma and toxic stress, which we know it causes mental health, anxiety, mental health problem, social problem, crime and drug use and dropout. But we discovered quite recently that these ACE have an effect on physical disease later on in life. Hypertension, diabetes, cancer, and so that's kind of a surprise that social issues would bring medical disease, not just mental disease. So it's quite an argument to have the medical community to shift a little bit. It's hard to shift very rapidly, but knowing that you can prevent these diseases by working with children with vulnerability is something very new, and all the